Hey, Tess.
Hey, did this work?
Hey, Dr. Fox.
What's going
Nice,
on? How are you?
nice to see you. How's everything?
Good. This is a big moment in my life.
It's nice to be together.
How are you, man?
Great, great. So let me take a moment to get started here as people begin to file in.
Okay.
Um, Actually, let's give them a few minutes. Let's give them a few minutes. So where you are in your office, it looks like, Dr. Fox?
I'm in one of the offices here, yeah, with the
Nice,
with the prettiest background, so
beautiful. Did
it's
you
all
do that
good.
artwork yourself?
No, not me.
So, all right, let me introduce myself. My name is Dr. Edward Nejat. I'm the co-founder and practice director of Generation Next Fertility in Manhattan. And I have with me today a very special guest, colleague, and friend, Dr. Nathan Fox from Maternal Fetal Medicine Associates. Dr. Fox went to medical school and did his residency at Mount Sinai in New York City. He then went on to do his fellowship in maternal fetal medicine, which is also known as high risk obstetrics at Cornell. And that's where we met. I was a
That's where we met.
resident, and Dr. Fox was a fellow. And I can tell you firsthand that he is not only an incredible and compassionate physician, he is an incredible educator. So, Nady, thank you for everything you taught me over the years. I really, really always appreciate it. Thank you.
Fantastic. Well, I'm happy to be here. It's a big moment in my life. It's my first Instagram live ever.
Oh, great.
Uh, I nearly had to fly in a team from Vienna to teach me how to do this, but with the help of Sarp Axel and thank God my children, we're on board.
Excellent. Excellent. So, we titled this event, The Curve of the First Wave is Flattening, and what happens next. So, obviously, we're going to talk a bit about that. And we're also going to cover some topics on COVID and pregnancy and how COVID affects pregnancy. What do we know? What don't we know? What type of research has been published thus far that can help give us some inklings on how COVID affects pregnant women. And of course, Dr. Fox has very good firsthand information on a lot of those topics, which is why we're very excited and fortunate to have him with us today.
Great.
So, the fact that the curve of the first wave is plateauing is really great news. We're seeing lower rates of hospitalizations, of infections, of deaths in the New York City area. And it's become pretty clear that that curve is flattening and maybe even beginning to decline to a certain extent with regards to some of those metrics. And it does seem like the social distancing measures that have been put into place are largely responsible for that. And society, you know, has been doing a fairly good job at maintaining those measures and ensuring that we are beginning to see some sort of change in the trajectory of this pandemic. One question, a few questions that often come to me are, when should I try to get pregnant? I've been trying for a while. I don't want to wait. Should I wait? Should I not wait? And these are all very personal decisions for patients to make, of course. All of those questions really depend on the specifics of one situation. And I encourage you to come and speak with us directly so we can help you make those decisions. And everyone's in a different boat. We have some patients who are younger and have higher egg reserve and may not have the same sense of urgency as some women in different categories with lower egg reserve who really don't want to wait another month or another few months before seeking treatment and trying to conceive. Women with lower egg reserve certainly feel more of an urgency, generally speaking, to try to get pregnant sooner, and we're totally on board with accommodating those patients. Of course, our office has been open throughout this entire pandemic. We never actually did close, and we're taking very strict precautions in the office to ensure that the risk of COVID transmission in the office is minimized to the extent possible. Any visits that can be accommodated by telemedicine, we are accommodating in that way. But of course, there are still visits that need to happen in person. Our pregnant patients, our patients who are undergoing IVF cycles or other treatment cycles. And we are taking several measures to ensure that COVID is not transmitted. We essentially assume that anybody could be infected, any staff member and any patient. Dr. Fox, do you make those same assumptions in your office?
Yeah, we're not doing universal testing in our office for a lot of reasons, one of which is just it's not feasible to do because you don't have access to the tests. It is being done on labor and delivery at Mount Sinai, so anyone who comes either in labor, is coming as a scheduled induction or C-section, they're all getting tested. But in the office, essentially, we're just following the Department of Health guidelines from New York City. There's some confusion because every city, state, and has differing guidelines. They're all sort of principled the same, but the details are a little bit different. So we've been following the New York City Department of Health guidelines, which have also evolved over time. So first starting with just a little bit of social distancing and then having fewer visitors. So for example, our prenatal visits, generally now women are either doing them from home on a virtual visit or they're coming in, but they're coming in just by themselves. And if their partner wants to be there, it's either via FaceTime or Zoom or phone or something like that. And then it evolved to everyone, wearing masks in the office when we see patients. So that's anyone who has any interaction is wearing masks. And so it has evolved a little bit over time. And, in terms of whether you assume they're positive or not, it's on the labor floor, we do until they're proven negative, because there it's really more procedures and deliveries and C-sections. And so the gear you have to wear is a little bit more involved. In the office, it's really just wearing a mask. And for our patients who we suspect are infected either by their symptoms or they have positive tests, we're generally just having them not come in unless it's emergent, in which case they go to the hospital, not the office.
Right.
And we've had a fair number. We've had a fair number of positive pregnant women in our practice.
I'm sure.
Actually, a high number. I don't know what fair would be.
Right. Obviously our patient populations are different. We screen the patients before they come in to see if they have any symptoms.
We do the same.
And if anyone is symptomatic, we urge them to stay home and isolate, unless, of course, it's an urgent visit. And in that case, we would take different precautionary measures. And thankfully, we haven't had to cancel any IVF cycles or anything like that due to a symptomatic patient thus far. But everyone's temperature is checked upon arrival, and we are limiting the number of visits at a given time so that there is adequate social distancing in the office in terms of number of patients in the office at the same time and number of staff in the office at the same time. And of course, every practice is doing, what they can to mitigate the risk to the extent possible. And I think we're all getting a little bit better at doing that day by day as we learn more in order to keep things as safe as they possibly can be. Okay, so I just wanted to touch on a few other categories of patients that we've been seeing over the course of the past few weeks and few months that may not fall into a category of particularly urgent by some standards, but really this sense of urgency really comes from the patient, and defining that, and limiting or accepting who is ready for an IVF cycle and who is not, I really don't feel like is my responsibility. I feel like it's my responsibility to educate our patients about the risks that are involved with coming to the office and going through IVF during this pandemic. But when it comes to a patient, for example, who may be younger and have higher egg reserve, but maybe she's about to lose her insurance due to an employment layoff, that creates another category of urgency that we have been seeing more and more due to some of the other factors that are involved in this pandemic. And some patients, just don't want to wait. They've been waiting long enough and they've been trying for a while, and they feel like they can travel to and from the office safely. And, for those patients, by all means, as long as they understand that there are risks involved with coming to and from the office and being in the office, and what the risks of COVID are potentially, during an IVF cycle or during pregnancy, we're, of course, happy to accommodate and take care of patients in that regard.
It's so interesting you mentioned that, because one of the hats I wear now is I have a podcast, so which is new. But
yes, and what is the name of that podcast?
Healthful Woman. It's my tagline here, or whatever it's called, my address here. But the reason I'm doing that is not to, advertise the podcast, but on Monday we're talking about that exact topic, which is, the idea of stopping fertility treatments because of COVID is a complicated decision, and it's ethically challenging because none of us have told women in general, you have to stop getting pregnant. Women who are conceiving naturally, we're not telling them to use protection, don't have sex, whatever it is. We're not telling them that. The country's not telling them that. The local government, Department of Health is not telling them that. So people sort of are maintaining their own autonomy over how they want to build their families, except women who are struggling with infertility. And those women are being told by some people, you can't come in and you can't be treated and you can't have IVF or you can't have any treatments for infertility. And that's difficult because you have one subset of women, in our society who are sort of given reproductive freedom, so to speak, and the other subset are not. And there's a lot of ethics involved. Now, obviously, it's a complicated decision because there's logistical issues, like you said, of coming to the office and being exposed themselves or exposing others or staff. And so it's not just that simple, but to have a blanket statement that women who need fertility treatments can't get them, I agree is probably not the wisest way to go. And, also like what you said about what is considered essential. I mean, I have concerns, I do, obstetrics and I do prenatal care and deliveries. And so most of that continues as it should. But what about someone who needs a colonoscopy or someone who needs an echocardiogram or someone who needs a mammogram, and all these get held for 2 months? For most people, it doesn't matter, but what about the person who does have an early colon cancer and now it's going to be delayed by 2 months, or someone who does have an early breast cancer, right? The reason we screen is because somebody has these conditions. And so the idea of putting it all on hold for 2 months, while I understand it, it's reasonable from a, infection control perspective. There's definitely consequences to that. And I think that we have to be very mindful about what those consequences are. How do we minimize them, and maybe rethink how much of this avoidance of medical care is A, necessary, and B, helpful, because it could also have harm to it. And I think that's something that we're all trying to figure out now in this, deliberation of when to come back to the world and what needs to be done.
Yeah, I completely agree with all of those points. And it's interesting because now we're beginning to, as a society, think about what is opening up society actually going to look like, and what, okay, right now, doctors' offices are considered essential. They always were. But come, say, May 15th, when, the quote unquote pause is going to be loosened, supposedly. We'll see if that date is a moving target or not. But it's going to be interesting to see, what parts of society begin to loosen up and what parts are still considered to be not essential enough to, to open up. Like, I don't think we're going to go straight to a 70,000 person concert on May 16th, and that's probably wise. And, the strategy of opening up in a slow, deliberate, methodical manner with the right tools in place is largely what I think is going to dictate how the next wave of this virus may or may not hit us. If we open up too fast and we don't have proper tools in place, such as treatments, contact tracing, obviously vaccines are a long way away, and some of the other tools that we really need to have, this could bounce back more quickly than we want it to. So it's going to be interesting to see how that all takes place. And of course, testing. That's, it's an important topic that you touched on. We still don't have sufficient testing to, test all of the people that we would like to test. In an ideal world, the perfect test would be simple, inexpensive, easily accessible, and give us results within minutes, and could be just mailed to everyone's home so they could test themselves before they walk out the door. Eventually that may be available, but it's going to be a long time before we have access to something that helpful.
Yeah, I mean, all the data on, everyone's arguing how many people have been exposed to it, and we don't even know. So because we don't know exactly what is the, fatality rate. We know how many people that died, which is a lot, but we don't know what the denominator is. So we don't know whether it's 3% or 2% or 0.1%, because you have to know how many people were infected, and we don't know that.
Right.
And the antibody tests that are being developed, there's 20 plus antibody tests that are out there, and we're not sure if any of them are reliable in terms of actually, if you get a positive test, it means you're immune, and a negative test means you're not. The data on that is still to come. And right. Like you said, until we have better data, we're not going to really be able to make reasoned, or maybe not mathematically reasoned decisions. So that's why everyone's sort of arguing exactly what's the best way to reopen, all these things. And the reason there's so many different opinions is not just because people often disagree about stuff, but it's because we don't have the data, upon which to base it. And so, because based on these numbers, you may have different recommendations. If I knew that 50% of everybody was already infected and is better, then I would be much looser about letting people out, because it wouldn't matter as much. But if only 1% of the population was infected and there's 99% of people who are susceptible, that's obviously a different situation. And it's also the same thing for who's really at risk in terms of age categories, and maybe the lowest risk people should be let out first. So that's one strategy, or smaller groups and bigger groups. There's different ways to look at this, and I'm not an epidemiologist, and I'm not an infection control specialist, but all of us are just sort of trying to figure out how to do this based on information that isn't perfect.
Great. We have a question from one of our viewers that I think would be a great question to answer on this forum. How long after being tested positive for COVID should you wait to try to get pregnant?
First of all, how do you know there's a question? I'm learning.
I think because I started the Instagram Live, I have the luxury of seeing everyone's comments on the feed.
Excellent. All right. For all those watching, I apologize for my ignorance. Can you repeat the question?
How long after being tested positive for COVID should one wait before trying to get pregnant?
So it's a great question. I think the short answer is no one can say for sure what the answer is, but I would say there's no reason to think that having tested positive would somehow put you at increased risk for some complication. I mean, if you think about it, from the time you try to get pregnant till you're actually pregnant and there's a developing embryo is, as you know, several weeks. And so there wouldn't be any reason to think it'd be an issue. And as far as we know, at least on preliminary data, this particular virus is not one that is dangerous to a developing embryo or fetus in terms of birth defects, in terms of brain development, whatever it is, which is different, for example, from, let's say, Zika virus, which was a virus that was implicated and linked to a lot of fetal abnormalities. And so we didn't really predict that this virus would be dangerous to developing fetuses, because it's more similar to things like SARS and flu, and it's sort of related to that. And those have not been a problem for fetal development. The only exception is if someone gets violently ill in the first trimester, and they have low oxygen and have high fevers, but that could be due to anything, and that wouldn't be great for pregnancy. But just being positive, I personally would not tell anyone that to wait at all.
Great. I totally agree with all of those points. It's very interesting that, initially when COVID was like 2 months ago, or even a month ago, I think there were the concern was greater regarding how COVID might affect pregnant women and how COVID might affect women in the first trimester. And as we have kind of began to come through, even just the anecdotal evidence that is being amassed does seem to be largely reassuring, in my opinion. Do you agree with that?
Yeah, I mean, whenever there's a concern about an infection in pregnancy, there's really two concerns. The second concern is the risk to the baby, right? So there are a few infections that can, when they infect the mother, also infect the baby and cause problems. Like CMV is potentially one of them, or toxoplasmosis, or parvovirus, but those are really the exception. The vast majority of viruses don't infect the baby, the fetus, or hurt the baby in any way whatsoever. The first concern, which is the primary concern, is actually risk to the mother, to the pregnant woman. And the reason is all pregnant women, their immune system is somewhat lowered. And the reason we think that happens is it's one of the ways over time women's physiology adapted during pregnancy so that they don't sort of attack the pregnancy, because the pregnancy genetically, right, is at most 50% theirs. You know, I know a lot of people you're going to see maybe 0% theirs based on, you know, egg donors or whatever. And so the thought process is pregnant women, their immune system is lower during pregnancy, which is not so good if you get an infection. So if you look at data from like the flu, pregnant women who get, you know, the seasonal flu do much worse than non-pregnant women who get the seasonal flu. And that's true for several infections. So our big fear coming into this was, oh my God, we have this virus that seems to be pretty dangerous, and it seems to be really dangerous in vulnerable populations like people who are ill or people who are elderly. And we thought that pregnant women would be on that list. Sort of logically, you would think that. Mm-hmm. And actually, as the data's turned out, and again, this is really just anecdotal, people reporting what they've seen, it appears not to be the case. It appears that pregnant women are not at higher risk from this virus as someone who's, you know, same age, same health. Meaning, I tell people it's more relevant how old you are and what your health is compared to whether you're pregnant or not. Now, it might turn out that there are some effects on pregnancy that we'll learn, but those numbers seem to be small. I know in our own practice, we've had, I think, close to 70 women who have been positive at some point or suspected to be positive. And we had, I think, only one or two who had to be in the hospital for it. Neither of them had to be on a ventilator. And at least one of them had, you know, severe underlying medical conditions. And so we've been very reassured by that. Others have seen some pregnant women who have been sicker. But again, you know, someone's going to be sick from this, but it doesn't appear to be at a higher rate, at least, than everybody else. And that's been not just reassuring, but such a relief to us, because, I mean, we were all really, really worried about what might happen to pregnant women.
That's great. That's really very reassuring. Great news. What about the topic of preterm delivery and how COVID might affect the risk of having a baby prematurely?
We haven't seen it specifically, and you wouldn't think it would be just from testing positive. The risk of prematurity, you would think, might happen if someone, again, became really, really sick. So it wouldn't necessarily be the virus per se, like its own, you know, test positive. You wouldn't expect them to. Like women who get a cold don't tend to deliver early. People with the flu don't tend to deliver early. But sometimes if you have very high fevers, very poor oxygen, you have an inflammatory state in your body, that could lead to it. Or if someone's very sick and on a ventilator and they're getting worse, and one of the possible treatments would be to actually deliver the baby to make her oxygen requirements lower and her lung function a little bit better. I mean, but those are unusual and sort of heroic circumstances. But for the typical average woman who's pregnant, who's either exposed or happens to get it and has the typical course, which is like a bad cold or a mild flu or something like that, we would not expect her risk of preterm birth to go up at all.
Great. That's great. A viewer has a question. Any studies underway that look at COVID during pregnancy? I believe there's some registries that are being put together to get a better handle on this topic. Do you have any more information on that?
So there are a lot of studies that are underway in terms of in the US population, meaning we're actively studying people who have COVID now. And what happens sort of with research is the first things that are going to come out are just what we call like observational, like what have we seen? And so there was something that came out in the New England Journal last week, which was just literally a letter to the editor where they said this was the percentage of women who came on labor and delivery who tested positive. It's not, I mean, it is research, but it's not much other than just reporting a number. And so those are the things that are come out first. Things like I just said before, 70 women and very few of them were sick, and whatnot. And that's the first thing. And the next thing that's probably going to come out is a deeper analysis of that observational data, meaning are there risk factors in pregnant women that are different from non-pregnant women, meaning aside from age or health status, that would affect maybe how she does with, COVID. And so as we get more people to look at, you can maybe tease out some things. And then also all the things in terms of how many of these babies are going to test positive. Are there any impacts on the babies that we haven't seen yet that maybe we'll see in 3 months or 6 months?
Right.
Those types of things, or maybe treatments that were tried in pregnancy. And then so the data will get to be a little bit better. And then maybe some of the studies they're doing on medications to do them in pregnant women. So that's what's ongoing now. And that's very active in the US. Pretty much everybody is, who does this is looking at this. And then what's also happening now is people are starting to submit their research on the populations from China, from Italy, the populations that preceded us. So I also serve as one of the editors for the Green Journal, which is the OBGYN journal in the US. And there's a whole influx of papers that are being submitted on data that came out of China and Italy, for example. And so we've set up a whole system of how to, because you want to get them out fast. Typically when something gets submitted, it takes 6 months till it's published, but this is information you want to get out ASAP. So there's like a rapid review process, and there's a team of people who look them all over and triage them, send them out. So I think in the next month, we're going to start seeing papers from the US data that are what's called observational, and then from the maybe China and Italy data that are either observational, a little more detailed, or maybe even some more interesting results and more relevant results.
That is really a great insight that that you have as the editor of the Green Journal, which is, for all the viewers, a very, very prestigious and hard-earned position. That Dr.
I'm not
Fox
the
has
editor, I'm an editor. Dr. Cheshire is the editor. I serve at her pleasure.
Wonderful, wonderful. Okay, any closing comments, Dr. Fox?
No, I don't have a ton of closing comments other than, I assume most of your listeners are women who are interested in fertility treatments or have seen you or will see you or are thinking about seeing you. And just to know that, again, like what I said before, it's really important to know that just because you're not conceiving, sort of quote unquote naturally, you shouldn't feel marginalized and that somehow you can't do this and you shouldn't do this. And, reproduction is something we believe is, a right. And this is humanity. This is what we've been doing forever. Yes. And, this is obviously a challenge to overcome, both medically and more so logistically, but it can be. And I think that this requires not only some sense of reassurance, but also advocacy to really, everyone has to advocate for themselves and for others that this is something that's important. And so I commend you for being open and, talking to your patients and still doing this. A lot of people shut down during the past month. And I think that that's understandable maybe, but quite unfortunate, certainly for the, the population of women who rely on you for their reproductive needs.
Thank you. Thank you. It's, I really we've been trying to maintain contact, regular contact with all of our patients. Just
socially distant contact.
Yes. Telemedicine can be very helpful and useful in this day and age. And, it's just important that everyone has their questions answered because everyone has questions. So we encourage you to reach out to us. We are here for you. We are open and ready to take care of you. And it may be the right time for some of you, and it may not be. And that is totally fine. But the bottom line is it's an individual choice for every woman out there. And we're here to help guide you through that process. and do so in the most effective and safest way possible.
Right. And Ed is awesome. As he said, I've known him since a resident. He was a great resident, great guy. And I can say that unlike today, if you see him in the office, there's a much higher chance he'll be wearing a bow tie.
Dr. Fox, thank you for everything.
Thanks for having me. It was great.
One more time, Dr. Nathan Fox from Maternal Fetal Medicine Associates, one of the best maternal fetal medicine specialists in the city. Thank you for being with us, and thank you for all the information.
Thank you very much. This is great. I survived Instagram Live. I'm going to do it again. Take care, Ed.
Bye-bye.